Thanks, Nandini. After this interesting discussion, let's move on to the biomarkers of immunotherapy, that is PD-L1, MSI, and MSI and TMB. So we know that immunotherapy is coming in a big way in routine practice, and there are various biomarkers, but PD-L1, TMB, and MSI are the one which is commonly talked about. And PD-L1 is the one which is we are more friendly, and we are in most of the lung cancer it is being done. Even the cases which are not subjected to the biomarker testing, we want to make sure that at least we have baseline information of PD-L1. But is it, and the cases which shows high positivity for the PD-L1 are likely to respond. But this is marker is not very perfect biomarker, because there are some cases which, despite of high PD-L1 expression, can show poor response to IO, and there can be some cases which are either negative or low positivity, they can show the expression. So, but for pathologists and for the laboratory, it is one of the very challenging biomarker, because we face lot of trouble in standardizing and establishing it, because these markers were developed as a drug, disease, and diagnostic combination, because in this scenario for PD-L1, it is like a specific antibody clone which is to be used for specific disease or specific subtype of the cancer, and there are specific scoring algorithm. And the most problematic thing for pathologists is it has to be performed on specific platforms, like the one which is a companion diagnostic assay by for Pembro is to be done 22C3 assay has to be done on the DACO platform. Only then it is a companion diagnostic assay, otherwise it become lab level test. So if you see the companion diagnostic assay in this scenario, if you alter any step in the processing, it become a lab level test. And at the same time, even for the clinician, if you use, just to give an example, if you're using 22C3 for Pembro, it is a companion diagnostic test. If any other antibody like SP142, which is now hardly being used, especially in the lung, for Atezolizumab, it is a companion diagnostic assay. But if you use this SP142 for giving Pembro, it becomes a lab test and not valid. So the commonly used tests are 22C3 and SP263, based on the blueprint study, which both phase 1 and phase 2 has shown the good concordance between these two assays. And when it comes for the evaluation of these assays, first and foremost important thing for the pathologist, we have to see whether your controls are satisfactory, because if and every time you have to run a negative control with these slides, in addition to the external positive control, which is usually a tonsil. Sample should be adequate, means there should be a minimum of 100 cells. Then determine the positive and positive cells. And CPS should, if you are looking for CPS only, then you have to look for the immune cells. Otherwise, it is only in the tumor cells, and then choose the control. So control tissue which is being used is a tonsil, which it has a good strong positivity as well as a weak expression in the interdendritic cells, and the rest of the lymphoid cells are usually negative. When we have to calculate the PD-L1 expression in the tumor cells, any expression, whether it's a complete or partial, need to be counted. And at the end, we give the number of the positive staining tumor cells, which are divided by the viable tumor cells, and the score has come. So as you can see from the picture, there are some cells which are showing weak expression, but they are also counted. So this is how it is different from the HER2, which is also a membranous stain, but where only strong and complete staining is accounted for calculation. Next is the calculation. When we calculate this, if you are using 22C3 assay, then the report should have a mention of it is a TPS. But if at the same time, if you are using Ventana assay, you should give only the percentage of cells. The pathologist should avoid the use of term TPS in those cases. It is not necessary to give the precise value of the or the count of the cells, even if it is if it less than 50. You can give it an increment of 5, and if it is more than 50, increment of 60 is also sufficient. But we have to be very careful, especially in the areas which are borderline or at the fence. It's like less than 1 or more than 50. Those areas we have to be very careful. TPS is still used in the lung, but as compared to, if you see most of the sites now, CPS is the common practice, but still in the lung we are okay with the TPS. Just to show some example, this one case with the nice staining throughout, no problem for the pathologist, and this case is likely to show excellent response. Another case which is negative, so what pathologist has to do, before signing out any negative case, we have to see it under 20x magnification, because there can be, the cutoff is 1%, so we don't want to miss that. And sometimes you see this type of staining which is very weak and focal, which you should not miss, and especially in the lung, because there are many alveolar macrophages which can pick up very strong expression for PD1. We should not misinterpret them as a positive cell. And heterogeneity also, which you have to keep in mind, but the good thing is we don't have to bother that when we are doing the calculation. So 1+, 2+, as well as 3+, all will come in a score, and the heterogeneity can be seen in whether the tumor is primary versus metastatic site. So these are the common scenario in which you can give the variable expression for the PD1. At the end, for the PD1, these are the components which should come into the report, that your type of the specimen, whether it is adequate or not adequate, your controls are satisfactory or not, type of clone, and in which platform it was used, and finally you give the score. So if we just to share the experience of PD1 in our hospital, this is for lung cancer, the most common PD1 asked, and this is one marker which shows higher positivity rather than negative. Around 60% were positive, but majority of them were low expressor as compared to the high expressor. Now moving to the markers beyond PD1, the tumor mutation burden, that is TMB, is one of the common marker which is talked about, and it has been used as a cutoff in various studies, especially not in the lung cancer, but also at other sites also. And if you see for the TMB, many of these panels, they are large gene panels which we don't use in our routine clinical practice. So most of the targeted genal panels, which are small gene panels, they might not be sufficient to give the precise idea about the TMB. So there are two ways to calculate TMB. The best way is to do the whole exome sequencing, and second option is through target gene panel, which is a sufficient large panel to give this information. Whole genome exome sequencing is practically, in clinical practice, is usually not feasible. So most of the people want to go for the targeted panel. And in this panel also, as I mentioned, the gene coverage should be sufficient, and only then you will get the information about the TMB. At least it should be 1.2 to 2 MB panel. Try to look for the content of this panel, and size of the panel is one of the very crucial thing when you are deciding the TMB. Next problem comes to the clinician when they get the report of TMB is what about the cutoff value. So I just want to please focus on the last column, where you can see there are some of the trials, they have used the number of mutation as a cutoff, and other has mutations per megabase pair. So the foundation medicine, which is one of the common platform used for the TMB and other genetic alteration, they have keep a cutoff of a 10 mutation as a reference, but is 10 mutation is sufficient to label as high or less than 5 as a 2 as a low TMB. That can be as a 2-tier system, but some people advocate that 3-tier systems might be a better way to decide on the therapy. Another challenge for the TMB is about the bioinformatics analysis, especially for the laboratory. It is more challenging because they have to focus only on the non-synonymous mutations, they filter out the germline mutations. So it is not a very simple bioinformatic analysis. So TMB, if you want to use it in clinical practice, it is full of challenges, and right from the pre-analytic error, there are a lot of analytic issues also, so that the precise value calculation of TMB, and many times you might see some of the reports even coming from the foundation medicine or the good panels, which come with the uninterpretable TMB. So there is a need to standardize the TMB similar to the PDL1. There are some reports has come like a blood TMB, can be used blood or liquid biopsy for TMB analysis, and some of the trials has also used given as more than 16 mutation per megabase pair in blood can be used as a cutoff, but not yet reliable in clinical practice. Last, about the MSI, although the role of MSI is still limited in in lung cancer, and for if you want to test for MSI, we have to use the 4 markers, and so that means you have to waste 4 sections for to perform this test if you want to use ISC. So recommended method is it can be used as a part of NGS panel, because some of the panel give the information about MSI. So to conclude, PD1 is till date the best validated biomarker for deciding immunotherapy, which is in the clinical practice. But if you want to go beyond that, we have to harmonize and standardize, especially the TMB in the clinical practice is a great challenge. Any questions or queries? I'll be happy to take them.
Question?
So are we using TMB for planning a therapy? Because the NCCN has removed that TMB.
No, can you repeat?
TMB is still useful in clinical practice in lung cancer cases.
Yeah, so there are some trials which are there, but if you are using TMB for the clinical practice, you have to be very sure about the panel, its coverage, and whether it gives the extensive coverage or not. Otherwise, that TMB might not be a reliable one.
2020, that NCCN panel has removed that TMB.
Yeah, so that is the reason, because most of the targeted panels they give and some laboratories even they have a low limited panel, they also try to give the information about the TMB, which is not a right thing.